Welcome to everyone. Very delighted to have you here today. And for those that'll listen to us on recordings, I know everybody's very busy. But we thought it'd be great to kind of get back together here the beginning of March. We're almost 2 years, I guess, since chaos reigned in 2020. And just touch base on kind of the state of telemedicine, kind of as we see it from a couple of different perspectives. So we're delighted to have Dr. Wasserman and Dr. Russell Libby here today to talk with us about their experience. I think these guys can probably do a better introduction of themselves than I can do. But Dr. Libby, do you want to tell everybody about kind of your current in-person and virtual care practice?
Sure. It's an interesting situation. So I started a practice in Northern Virginia outside of DC 42 years ago. Have grown along with the area so that we have 4 offices and 16 clinicians. Through that course of time, yes, I've done everything from the 24/7 solo doc to now having a more, let's say, mature approach. One of which was basically being somewhere else when the lockdown began in March of 2020. And at that time began doing telemedicine full-time, as everybody in the practice pretty much did. I had set up telemedicine as part of the practice prior to that time. We can talk about that later if you'd like. But ultimately, the demand was big, it grew, it became a very integral part of our practice. And thus far, it has become my solitary medical delivery vehicle. So my platform is telemedicine, and that's how I engage patients, and that's how I take care of them. I am not seeing patients in the office, although I have things set up so that can happen.
Yeah, I guess Russell, you and I've talked quite a bit about kind of the virtual health platform and seeing pediatricians. You know, some really, obviously everybody embraced it there for a while, and now some are kind of like going back to pre-pandemic of seeing things kind of cycle back. And so I'm interested, why did you choose pediatrics, and how do you see this as delivering great pediatric care now that you're not in the office, which I'm sure 46 years ago when you started your practice, you would never have envisioned. So I'm curious how that evolution has been for you from your start in pediatrics to where you see it now and what you can deliver virtually.
Right. Well, of course, my motivation, and most pediatricians, is going to be somewhat altruistic. Certainly there are affinities for kids and for thinking about your social setting and your community and what you can do to best contribute to the ultimate potential and outcome of the kids who grow up there. To me, that was really an important opportunity, and one where I felt in a lifetime I could give back way more than I could take from life. And it was meaningful, important, and I think that I share that sentiment with probably a lot of other pediatricians. And of course, initially, once again, it was that hands-on. We were giving all the shots, we were doing all the procedures, we were seeing the kids in the ER, taking care of them in the hospital. And of course, over the last 4 years, it has evolved tremendously, both in terms of the care we can provide, what we understand from those outcomes, as well as the vehicles by which we deliver care. So, as time went on, my younger partners didn't want to go to the hospital. They didn't feel that they had the competencies relative to hospitalists. That became a specialty in and of itself. And so we started to become a very office-based practice. We still see newborns in 4 different hospitals, but really that's a minor part, and one that's more, let's say, PR than it is necessarily medical care. But nonetheless, telemedicine was something I felt we had a very crowded suburban population. We needed to deal with the issues that were always impacting them for all kinds of follow-ups, whether it be for physical, sports physicals, follow-up on chronic medical conditions, ADHD, mental health issues, asthma, allergy, anything that we were managing. To have that 2-hour window in the afternoon when they didn't have an extracurricular event after school was really a difficult thing. And to travel for that period of time, to get into the office for a 15 or so minute visit seemed a little bit excessive. And when the opportunity to develop telemedicine in the office became apparent to me, and this was a few years before COVID and this whole transition, it seemed this would be really a wise thing to do. In our state, they had parity laws. They also gave us the opportunity through several payers to use a platform that they provided. And as long as we were in the office, we would get parity for the kind of service that we provided. Of course, with the public health emergency, that went away, and most payers are considering to continue that payment mechanism. But nonetheless, by the time COVID came, we had really established a pretty functional telemedicine component to the practice. And, you know, I had gone through the process of creating protocols, identifying conditions, and understanding where it could be used right now, as well as how that might evolve into the future. So I'll once again continue it to how that has evolved and what role it's taken in our practice, as well as address the question you had was, what are docs thinking when they think that they're going to go back to the office, when patients have had 2 years of telemedicine opportunities and are going to expect that as a service that they receive. So I'll let you get back to Dr. Wasserman.
It's great to have you, Dr. Wasserman. So
thank you.
Can you just tell us a little bit about your practice? I know you know Russell is doing a lot on the well care side via telemedicine. Right. I know you're doing the sick care side. Just kind of give the audience a highlight of your current practice.
Okay, so after a very successful career in primary care peds, about 6 years ago, I joined a rather large pediatric urgent care company. And a couple of years ago when COVID came around, we began a telehealth program, and I was one of the people who really needed to avoid that thing. So I became a champion for the telehealth program and was doing that exclusively for over a year. And then just recently, having had my vaccines and everything, now I'm doing some telehealth and some office, practice. So kind of a mixed bag.
That's great. And what drove you into this crazy world of pediatrics?
Well, I would have to say Milton Greenberg. When I was a child and I was sick, there was one human being in the world that could calm my mother down, and that was my pediatrician. That's what I wanted to do growing up, and that's what I did.
Yeah, that's awesome. That's great. Yeah, so Russell started down the path of telehealth pre-COVID, kind of trying it out, figuring out where it was going to fit. Sounds like right. you were pretty much thrown in with the masses of chaos of COVID. Did you ever imagine yourself doing virtual care?
Not a chance. Our telehealth program was really driven by the COVID pandemic, and that's what really got us started. It is actually something that had been talked about in the past, but with a successful office-based practice, it was never a priority until COVID hit.
And so now that you evolve, I don't know if COVID's ever going away, but as the chaos around COVID maybe is going away and sick kids are coming back, how do you see it melding in with your pediatric urgent care after hours practice?
That's a really good question. And for the past year and a half, the main driver of telehealth care has been COVID, but we are starting to see some repeat customers. And I think that the convenience, the ability to have a doctor's visit from your own home has been something that's very enticing for the patients, especially if they have a minor illness and really don't feel like they need to, spend an hour waiting in our office to be seen and such like that. And of course, in the future, whether or not the pandemic is over, the regulatory agencies and the insurance companies are going to think it is. And that's going to be what drives us in the future. If they continue to pay for things, we're going to continue to do it. If not, then I think that it'll, kind of dwindle down. We intend to keep our telehealth program running, just a matter of what the demand will be.
Right. So Russell, when you think about virtual well care, I know that was a hot topic, and I think we did some webinars a year ago or so, or maybe 2 years ago on virtual well care. Now that you're providing well care post-pandemic or in the ongoing phases, how do you think the care is that you deliver as a pediatrician and what you're able to deliver virtually versus what you could do in the office?
I could talk a long time about that, Mick. You know, I will start by saying that the connection I make both with the family as well as the individual patient through this medium, through this virtual encounter, is a lot less stressed and a lot more connected than I feel that I ever had in my office. With kids screaming down the hall, getting vaccines, or in the lab, with commotion and movement, and people frustrated with waiting in your waiting room or being stuck in traffic and not showing up on time. The diversity of impositions and unpleasant elements really are eliminated in this kind of interface. And I feel very comfortable with it, and my patients feel that comfort and are very comfortable with me. So I think that allows for a huge piece of what we do. Yes, the hands-on, the listening to the lungs, the listening to the heart. That's all an important component of what we do when we put our hands on patients. But you know, to me, it has become much more of a symbolic connection than necessarily a diagnostic connection. There are situations where that diagnostic skill is extremely important, but my observational skills really do carry me through this. So I find that both from a sick as well as a well side, I understand what I'm doing. I understand what I'm trying to accomplish. And it's not necessarily, I'm going to listen to your heart and tell you if you have a murmur or not. It's more about the psychosocial and developmental issues and your general state of health and the advice that we are missioned with giving when we have well and sick encounters. And if you have a feature or a need or something I'm suspicious for, or that at any other opportunity we can put hands on, that's something that I note in a chart or something that I refer to immediately and set that up, as you know. But I find that my ability to provide care, both in terms of screening sick kids, treating sick kids, and now, you know, you look at COVID and we're doing home tests for COVID. My God, we can do home tests for the flu, for strep, urinalyses. You can buy those test strips, you know, at CVS. It's a new world, and one that patients, as they experience, start to prefer relative to many of the screening opportunities. Yeah, they miss me. They want to say hello. They want to hug me. Right? I want to hug them too. But it is where we're going, and we're going to build this out in ways that support that kind of care so that people have the option and their access will improve.
So when you look at the periodicity schedule and how often you're seeing patients and the well care needs, I mean, do you feel like you're doing I'll just say an adequate job? Like, do you come away with provider satisfaction that you're able to provide the well care that they need, you know, virtually, and or maybe even more efficiently or effectively than what you can do in the office?
You know, we require that much of the well care, especially the first 2 years of life, be through a hands-on visit. So, you know, and that connection and the opportunity for immunizing can take place. Now, through COVID, we created a curbside immunization and laboratory component that made it a lot easier. And we may or may not continue to do that, but we will have vaccine clinics where people can come in a quick measure to get a vaccine. Nonetheless, you know, I find that I take every opportunity to provide preventive care in any encounter setting that I see a patient. And if I'm missioned with doing a virtual checkup, I make sure that they understand that there are certain physical parameters that need to be followed up. And if that is something that I think needs to be done more urgently, you know, there's growth failure, there's some physical finding that is a little bit of concern, I refer them to the office. I set up that appointment. I can do it on the same day or the next day. If that be the case, we'll find something convenient for them and make sure that that's covered.
Yeah. Excellent. And Louis, I know you and I talked about kind of sick care as a pediatric emergency medicine doc. That's kind of how I got into this, thinking about how can we handle these sick kids and triage and those kind of things. Right. So I know when you got started, Louis, you were like everyone else, myself included, of, hey, maybe I can take care of a runny nose or a cold, but what if I need to take care of this or that? Has your repertoire of illnesses or concerns expanded over the last couple of years, or how do you see that when you get home?
Well, I would say that it has expanded somewhat. There are things that you can do with a home, with a telehealth visit that can in sometimes replace, what you do in the office. For example, I cannot auscultate a chest, but I can have the child take his shirt off and watch him breathing and see if there's retractions or tachypnea or that kind of thing, and get an assessment at least of, is this somebody that needs to be seen in person or not? I can't palpate over the McBurney's point, but I can have the child do a jump test, and if they can jump up and down a few times without getting a lot of pain, then I can be pretty sure that I'm not dealing with an appendicitis. I took a look at, I actually followed my own statistics for the first 6 months to see, okay, what am I seeing? What am I referring to the office? I do have the luxury of being part of a large healthcare organization. And we actually scheduled our telehealth so that if we need to, I can tell them, hey, you got to go to the office. And so I've got that backup. I find that we're sending about 10%, maybe a little bit less, of the children who come in for a telehealth visit, we're sending to the office because they really need to be seen in person. So that means we're taking care of about 90% of them via telehealth. I do have to credit, that over the last 2 years, we've done a lot of looking into our triage policies and stuff. And so even when somebody calls for a telehealth visit, the nurse is looking at the case and saying, okay, is this something that's appropriate for telehealth, or should we just tell them to come to the office? So a lot of those folks are getting weeded out before I even talk to them, that really need to be seen. Did that answer your question?
Yeah. And has anything really surprised you that you're taking care of that you thought when you started you would be like, man, I'll never take care of that? Or, with that chief blade, like abdominal pain, I think is a good one. It's one that I think a lot of folks were hesitant of, but
that's definitely one that I originally thought, well, I'm just going to send all of these to the office, but actually most of it's going to be stomach viruses, and you can treat that virtually if the child does not look ill. If he looks dehydrated, or if he has a positive jump test, I'm going to definitely send him to the office, or possibly even refer him to an emergency room. Yeah. And again, I've got the luxury of being able to do that. Also, for things like urinary tract infection, most of the diagnostic information comes from the history, as they told us at the beginning of medical school. I see Dr. Libby appreciating that comment. And we can get a good history, a thorough history over the video. And then for some things like sore throats and urinary infections, we just send them to the office to have the test done. It still is a convenient thing for the parent. And, we're able to provide that care with the backup of having the ability to do those tests in the office. So that kind of surprised me. The other big surprise was the incredible regulatory tangle that is involved in telehealth care. The locus of the visit is where the patient is. So if I'm in Florida and my patient who lives in Florida and has seen us 10 times is in Tennessee on vacation, I can't see them by telehealth because I'm not licensed in Tennessee. So issues like that come up. during the pandemic, there's been a lot of states have passed laws that say, okay, for specific purposes, if your patient is in our state and they have an established relationship with you or not, or blah, 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 then you can do a telehealth visit because they're stuck here and they can't travel because they've got COVID or whatever. The summary of all those state rules and when they expired and when they went into effect and all was something like 18-page spreadsheet. So it's very, very complicated. And as a group, we just decided that we're just going to keep our practice in Florida and not try to handle those particular situations. But I can imagine that if you had a multi-state telehealth program, that could have gotten very, very confusing.
Yeah, yeah. No, that's great.
You know, Mick, I'll sort of add on to that. There have been so many opportunities for us to learn how to assess patients, and I can say that probably 30 to 50% of the sick visits I see in my office probably didn't need to come in for that. They were parents looking for reassurance, conditions that really didn't have some more grave background to them that would require a workup or an antibiotic. And as we've evolved, we've really improved that outcome relative to not using antibiotics unnecessarily. I can say that I may prescribe an antibiotic once every 2 weeks. I mean, it's almost impossible to get me to do that, even in the office when I was there, but especially now. You know, I haven't missed an otitis media. I haven't missed a pneumonia. If I think someone is having an increased respiratory rate, has chest pain when they breathe, or anything that I consider extraordinary, I set them up with my office. They go in that day. Yeah, we may up code to cover the combined visit, but it's one visit. Unfortunately, we're in a payer system where, you know, they don't incentivize access, convenience. They actually incentivize volume and margin. So, you know, if that evolves, great. But, you know, I wrote this little article called The Officist. That's what I look at. My offices and their clinicians as the place I send my patients when they need that extra care. Like I send them to the hospitalist in the hospital if they need to be in the hospital. But going back to the acute abdomen scenario, you know, a parent really can provide a remarkable facility of palpation and communication, and they learn as you work with them how to assess their kids and to make it a more comfortable opportunity. And for them to save the time, effort, and money for not having to go to your office to be able to get that reassurance from you and you to get that sick visit fee because you need to bill for it, you know, it is where we're going. And I think people need to understand this is part of your practice, not, you know, separate from your practice. This is how you complement the care you provide, improve access, create that committed patient-centered medical home so that the patient identifies with you, and has a good relationship in a way that they feel comfortable. It's amazing what I can do when I'm on that call or in that virtual platform. I can look in the chart, I can find the documents, I can Google things, I can send them an email, I can fill out a form. I can do that in the scope of the moment and not have to spend an extra half an hour afterwards and then forget what I was going to do. I can see if the pharmacy they're thinking is on whatever road is actually there, send the prescription while we're talking. You know, what are you talking about? This is a remarkable evolution and elevation of the care that we provide. And, you know, if docs don't get it, they're going to lose it.
Yeah, I agree 100%. And also you know, it's even like abdominal pain, for example, when we think about it in a finite one-time visit, but I think we all know that abdominal pain has a course and a direction, right? So the child who vomits once and runs to the ER is probably not going to declare themselves at hour 1, right? It's going to be 12 hours, 18 hours, signs and symptoms to watch for. And, you know, or we see the kiddo that's waited for 3 or 4 days and has a perforated abdomen, right? So all those kind of things in there. So I'm intrigued by what you said though, Russell, because I think, I read all the studies on telehealth. I read everything that's out there. Patients want it. It's convenient. Hey, we can do it. But I'm reading more and more of physicians saying, I just want everybody to come in the office, or all my patients tell me they just want to be in the office. And I get the sense that the physician side is is again the barrier. There's certainly regulatory barriers and things like that, but even how do we overcome the behavior of ourselves as clinicians to say, like, that virtual care can be part and parcel to what you do, similar to telephone care, in-office care, referral to the urgent care, the ER. How do you see that from a behavioral challenge with your fellow pediatricians in your practice?
Well, I think that patients are going to demand it. We're giving away care when we do it any other way. Now we have, the nurse triage, but we set up 4 or 5 patients in the evening so that those calls that need to be addressed on a more acute basis can be seen, and we, in our value-based contracts, can get the credit for not sending them to the ER. That we don't spend the time back and forth on the phone, that we can actually eyeball the child. These are improvements in the way we deliver care. Listen, we watched RBCs and urgent cares come and replace a lot of our sick care. And of course, we may sort of find that, our well care is compensating for it. It's not adequately, but we have lost that opportunity. And believe me, what's in the works is only going to further stifle your opportunity to have a successful business. Yes, right now there's a demand and you have been able to cope with it, but it's not so easy. The business of medicine is one that is being financed differently than we ever had imagined. Private equity and other kinds of opportunities for people to start to support CVS, Walgreens, any of these other entities from creating their own virtual and more convenient access to care. These are going to start to get in the way of how we as physicians can operate. And if you don't understand, maybe you needed extended hours, maybe you needed Saturday and Sunday hours, you lost those patients and they're getting used to going to those urgent care centers. And in fact, when you have a sick visit opening, they aren't even calling your office, they're just going to those urgent care centers. That was when we didn't use telemedicine. Now they're going to come back. Think about it. Where do they want their care? Do they want it from you, or are they just going to start to say, okay, wherever I can get it, I just need something right now?
Yeah. And Louis, from your standpoint on your staff, do all the pediatric urgent care physicians embrace telehealth, or are you getting some resistance on, hey, we should just send them back in the office and close up our telehealth shop? Or how does your group look at telehealth?
I certainly have not seen any resistance. During the pandemic, when things were very busy, the offices were overwhelmed. And I think they were happy to have an outlet for some of those patients to go to. And having the telehealth program added an additional provider, so we were able to actually take care of more kids in a day. I think that the demand, you're going to see some demand from patients who we're starting to get some repeat customers. We're starting to get people who, I had a telehealth visit last month for this, and now, it's just such a convenient thing. So they come back for another visit in the same way. But again, the drivers of this is really not patient demand, it's who's going to pay for it. And as the pandemic wanes, I am very interested to see, because the actuaries are going to tell them either, okay, this is saving us money because we get a lower level of visit, or they're going to tell them this is costing us a lot because we're providing more care, and that's what's going to decide where that goes.
I know we're squeezing down in time, Mick, but I want to address, there was a question on co-payments and deductibles for non-COVID-19 related visits. And I will say that in any of those situations, as if you came into the office, you are informed that this is a visit that requires a copay, and that you will be required to do that prior to the visit. And when we have patients come to the office, they do their copay before they have their visit. And for the majority of the time, that works pretty well, unless they get frustrated because they've been there for 75 minutes waiting to be seen and want a refund because they're leaving to go to the urgent care down the street. But nonetheless, we've done that successfully. And I think when patients start to realize they're getting the same level of care, but it's an easier medium and they don't have to get in a car and they don't have to sit in a waiting room with other sick individuals, and they don't have to go through the rigmarole of coming into an office, but they are getting the outcome that they were desiring, that will be an acceptable alternative. Payers are looking at this positively for the most part, and I have had a fair amount of interface with them, examining how they perceive this and whether they think, okay, we can't wait to get back to the way it was. In fact, this is a more efficient and economically sensible way. And in fact, they are creating telemedicine services that ultimately could replace us as primary care docs, as well as urgent interventions. You look at the virtual first programs that a number of the payers are implementing, be aware that's happening. So, to me, this is a patient experience. You're trying to make it efficient. You're getting paid for the work you often didn't get paid for, if it was a phone call or went through your advice nurse. Lou put a very important concept out there, and that is understanding how your triage system works and making sure that it understands what needs to come in or what needs to be screened or can be screened through a telehealth encounter.
Yeah, I mean, I think that's well said. And I think the other thing that I've always been passionate about is I want kids to see a pediatrician, right? I mean, I guess we're all biased, trained pediatric, so giving parents better access to the medical home or that local connected pediatric urgent care or things like, I mean, I just see so many kids from the ER perspective that have been to other places, haven't been to their pediatrician, haven't been to a pediatric urgent care, have gone to the retail clinic or, winged it on Dr. Google or, done those kind of things. So the more accessible we can make care to a trained pediatrician, and I think you both, eloquently said, I mean, training and experience matters, right? I mean, taking a good history, understanding what the differential diagnosis is, when to say, hey, I can take care of this via telehealth, or no, this needs an in-person visit. That's just not, that's not something that just pops up on a video screen, right? That's years of experience and training that is behind it. And I think the more patients we can get to understand that, but also pediatricians have to be accessible to do that, because otherwise these families just go, right? Just go, and there's more opportunity for them to go elsewhere than to kind of stay connected into that local pediatric network. So
could I just add something to a prior question, which is we talk about what we cannot do by telehealth, and you have to respect those limitations. However, there's also things that you can do, that you can see via telehealth that you don't see in the office. For example, the interaction between the child and his siblings. Sometimes I see a patient on camera and I don't look just at the patient, I look at the whole screen. And sometimes I'll see a bunch of pictures on the wall of the patient that I'm talking to and the family, and maybe the child's name in big wooden letters or something like that. Other times I see toddlers running around in the background and people shouting, and realize that this is a little different environment. And so it really gives you an insight into where this patient's coming from and what kind of attention that they're getting at home and things like that. So I just wanted to add that's something that's not really available in the office. You don't get to see that.
Yeah, I think that's great.
That's for sure.
Yep. Yeah, we had a pediatrician that talked to us about one of her great cases was, an asthmatic that she couldn't get controlled no matter what. And then she did a telehealth visit and saw Uncle Joe smoking in the background and mold on the walls and those kind of things, like, maybe this is part of the problem. Maybe we should address that. So thanks for the insight. You all take care.
It's been a pleasure.
All right, take care. Bye-bye.